As a society, just people who suffer from sickle cell, you are aware that you will go into crisis and you have children, and maybe there are times you may need support.
Our association is Sickle Cell Association of Ontario. This is our 30th year. Miss Lillie Johnson, the founder. She founded it 30 years ago, and she was recognized with the Order of Ontario in January of this year. This year, basically trying to fundraise for programs, our social programs, our educational programs such as seminars, our educational conferences, one-on-one counseling with families that get to know a little bit more about sickle cell. Also, advocate for youth that are in school, and also advocate for those that have gone past being a patient in sick kids and they're on their own and need to be able to, live a productive life.
Okay, so I'm sure you know the goal of this afternoon is to raise money and community awareness for sickle cell disease. Now, I have been tested and I am not a carrier of the gene. My cousin, Serena, who is working hard in the back there, she is, so I'm very familiar with sickle cell and its effects on a family. So it's important today that we support the cause and the programs, educational programs, which include seminars for the healthcare and social service providers and educators, one-on-one and family counseling and workshops, regular child advocacy for schools across Ontario, employment advocacy for those with sickle cell disease in the workplace, because as you can imagine, if you are ill and you have to take time off, a lot of people are not familiar with the disease. We also need to boost continuing social support programs such as parent, youth, adult support meetings, emergency financial support for SCD patients, community outsourcing for individuals requiring help outside the medical aspects of sickle cell. But most of all, our mission is to serve the community as a recognized voluntary agency that endeavors to optimize the quality of life for individuals and families with sickle cell disease. Now, today you paid your money and you're going to get your money's worth. We have lots of entertainment, including comedians.
My brother's girlfriend, she's Jamaican, so she thought she was going to get one over on me. She's like, yaks, do you know what you're eating?
Dancers.
No one's beside me. You are he who...
Singers.
I'm split in 8, turning them sideways. Duplicate the bidding process times 2. Even in our reincarnations, I still want to be
Raffles, Dutch auctions, a 50-50 raffle, a grand prize, and of course, excellent food. Well, our guest speaker, Dr. Larry Grossman, is going to speak on his experience with sickle cell anemia. But first of all, we're going to stand for the national anthem. Then I'll introduce Dr. Larry, and then we'll take it from there. Please stand for the Canadian national anthem. After a 9-year academic career in Vancouver, Dr. Grossman and his family returned to Toronto in 1985 to join the medical staff at the new Scarborough Grace Hospital. Here he became involved with patients with sickle cell disease for the first time. Please welcome to the stage Dr. Larry Grossman.
10 minutes, and she said she'd be sitting here with a stopwatch, so I'll try to be quick. I want to do a couple of things. First of all, I want to tell you a little anecdote that goes back to when SARS struck this city in, I think it was 2003. We at the Scarborough Grace were the hospital that really started this disease for a variety of reasons. And at one point, instead of having our usual complement of about 300 patients in hospital, we were down to 28 patients. But we had to discharge everybody. Staff were getting sick. Staff didn't want to come into work. And the only people that stayed in hospital were people that I was looking after on our palliative care unit, and a few other people that were just simply unable to be transferred somewhere else. One of those was a young patient with sickle cell disease. And she'd been put in a 4-bedroom where she normally would have been looked after with 3 other patients in the room. But because the hospital had emptied out so much, she was in a room by herself, and I walked in around, I think around 10:30, 11 o'clock one morning, and she was looking out the window, and I went up to her, can't use her real name. So I said, Jane, what's wrong? Are you having a lot of pain again? And she said, no. She said, but there's nobody here. I'm all alone. Nobody's coming in to see me. And to me, that's a metaphor for what patients with sickle cell disease go through. And it was my understanding of that, the emotional aspect of that disease, that was so typified by that little anecdote, but it was that type of attitude that people had towards sickle cell disease that really led me to meeting with the patients and the family and the staff and some of the physicians and administration at the hospital and putting together my protocol. This is a genetic disease. The disease was first described from a sort of an anatomic point of view in 1910. That was the first time anybody realized what the symptoms of sickle cell disease were due to. It was because these very rigid red cells were blocking the circulation, and wherever that blood should have been flowing, it stopped flowing, and that was causing pain, it was causing strokes, it was causing problems with the eyes, etc. It became the first disease known to have a molecular basis in 1949. The gene was described, the gene product, which was the abnormal sickle cell, was described, and the researchers at that time were able to tell that this was a substitution of a single amino acid in the molecule that's called hemoglobin. Sickle cell disease, you take one amino acid out, essentially of that brick wall, and put an abnormal amino acid in, or put it in the wrong place, and what you suddenly get is a hemoglobin molecule that's like a jellyfish sort of floating through the ocean. You've now got a shark fin. It's rigid. And what that does is it blocks the circulation. Because it's a genetic disease, we can't prevent it in ourselves. There are limits to biologic science and theology, and we have yet to figure out a way to choose who our parents are going to be. Put up your hand if you know your status with respect to sickle cell disease. Folks, that's less than half the room. This is a disease that's totally preventable. The symptoms we can deal with to some extent. The disease is totally preventable. You all need to be tested. And next year, when you repeat this exercise, I hope you're up to about 3/4 or 80% that put up your hand. The College of Physicians and Surgeons, there's a tremendous concern about the use of opioids and powerful painkiller drugs in the environment. But I think if I tell you what we did at the Grace, you might take this approach to your doctor and to your hospital and see what you can do about getting them to do the same thing. What we realized was that one of the things that happened when patients with sickle cell came into emergency, the commonest problem with patients with sickle cell disease is that they had painful crises. These crises can come on at any time. There are some things, and Zachary alluded to them, that you can do to prevent them. Keeping yourself well hydrated. If you have a fever, get treated as quickly as possible and maintain your hydration. Avoid atmospheres that are low in oxygen, or take extra oxygen if you're going to be in that kind of atmosphere. Avoiding anything that puts a lot of stress in your body that might upset the acid-base balance. Those are all things that precipitate sickle cell disease. But basically what happens is patients end up with painful crises. They come into emergency, and I hate to say it, but there is still some racial bias in this world. And you're a black person walking into an emergency department, often young, teenager, early 20s, saying, I've got pain, I need something for my pain. And unfortunately, in many emergencies, the first thing that people will think of is that here's a drugstore. Even beyond that, even if they recognize that you've got sickle cell disease, there's so many people who are unfamiliar with and uncomfortable in dealing with this patient that you have to go through the whole rigmarole of telling your history, waiting for your old records to come back, waiting for your lab tests to come back, all the while that you're in pain. And so when we realized that this was absolutely not the way to treat this disease, and to be honest with you, this didn't come from me. This came largely from the patients and their family members we decided to look at what other ways we could possibly manage this. Now, one of the things that is important in managing this disease is dealing with the emotional aspect. Because every morning, somebody with sickle cell disease wakes up with pain, they think, uh-oh, is this going to be it? They know that their survival is potentially shortened by this disease. So there's a tremendous emotional aspect, and that emotional aspect becomes worse if you're waiting for care, and especially if you're waiting for care in an environment where people don't really seem to be caring very much about your problem. So what we did was we decided that we would have a set of orders individualized for each and every patient, so that then when they walked into the emergency department of Scarborough Grace Hospital, they simply had to say their name and that I'm one of Dr. Grossman's sickle cell patients. There was a binder at the desk that had all their orders written out, and it had to be individualized. Nursing will not accept what they call sort of standing orders. You can't have standing orders that apply to any patient X, Y, or Z, because then the nurse is having to use their judgment, and there are reasons why that isn't allowed by the nursing college. But if you make the order specific, so it's got the patient's name on it, it's got my signature on it, I outlined for each one of the patients, I got to know the patients, I got to know what medications worked for them, what medications didn't work for them, what patients liked to have their mother in the room with them, what patients did not want to have their mother in the room with them, what patients needed more fluid than others, and in particular for some patients, the fact that they were so anxious that they needed something to control their anxiety as much as they needed to control their pain. So there's a little blurb about each patient, and then the orders, and the orders were signed by me, and I reviewed those and revised them as necessary every 6 months. And I think that that had a very dramatic effect, both on the staff in emergency and on the patients. First of all, it gave the staff in emergency the confidence that they could actually look after these patients. They've got the orders, they've got the little bit of a history on the patient, they've got all the medications listed, they would just go ahead and do it. So patients were often in and out of the emergency before I was even called to come down and see them. A dramatic change from before. I think from the patient's point of view, the huge benefit was that they got their treatment almost immediately. Very rarely, and only if the emergency was really, really busy, did they have to wait. The nurses went out of their way to find some way of getting them in, put them on a stretcher anywhere, get them started on their IV if that's what they needed, get their oxygen going if that's what they needed, give them their medication to control their discomfort and to control their anxiety. And we were able to demonstrate that it dramatically shortened the time in emergency, and interestingly, it also dramatically decreased the admission rate. So I think this was a very beneficial protocol. I am very sad that it has not been maintained since I left. It does need a doctor that is going to take the responsibility for writing these orders, getting to know the patients, revising them on a regular basis. And there are unfortunately just not enough physicians around that are willing to stick their neck out like this. This is, as much as anything, an advocacy group. You are the people that should feel empowered to go to your doctors, go to your hospital, and get this type of approach promulgated. It's not going to be easy. I remember I gave an address down at Sick Kids Hospital several years ago, and there was a lady sitting in the audience then who had a kid, and she said her, I can't remember, was it a daughter or son, had been in emergency at Sick Kids. Sick Kids is one of the premier teaching hospitals, pediatric hospitals in the world. Her son or daughter had been at Sick Kids 47 times. And she said, every time, I have to go through the same rigmarole. Why does it have to be like that? And as far as I know, as of today, Sick Kids still has not changed that approach. It's up to you.